1 in 5 Americans will develop skin cancer at some point in their life. And this is the most common type of cancer. So we get patients who are dealing with their very first skin cancer. And so they have no idea what to expect. And hearing the word cancer is scary.
Welcome to That's Darn Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Welcome to That's Darn Good. Today, my guest is Dr. Ramiz Hamid, and Dr. Hamid is dermatologist at the Dayton Skincare and Cancer Center. Welcome, and thank you for joining me.
Thank you for having me. It's a pleasure to be here.
Yes, somebody else that's in Ohio. You're not originally from here, so I'd love to hear your story and how you got into dermatology in the first place.
Sure. Well, it's not too long of a story, to be honest, of how I ended up in dermatology. I'd always known I wanted to do medicine from a young age because my youngest brother had some health issues as a child. We spent a lot of time in hospitals, got to see physicians kind of close up and in action, and was really impressed by that. And so I knew I wanted to go into medicine, didn't have any immediate family in the medical field. So I got to medical school and sort of kept an open mind in terms of my specialty choice. It really wasn't until I got to my last year of medical school that I did a rotation in dermatology. And we had a great dermatology department at the place where I went to medical school at Wake Forest in North Carolina. And so I was just, met some folks who really took me under their wing. I love the patients and the kind of variety that you can get in dermatology with the procedural side of things, the medical side. I like the fast pace. The stars aligned, and here I am.
That's awesome. So you were a fellow, and was that an easy choice for you to just decide dermatology?
I went through dermatology residency in North Carolina, decided to stay at Wake Forest, got great training, kind of a well-rounded training, both in the medical and surgical aspects. I always sort of knew that I had an interest on the surgical side of things, wanted to pursue additional training. I ended up moving out to Ohio, worked as a general dermatologist here last year. And that year solidified my interest even more in the surgical side of things. I'm doing dermatologic surgery, and I really wanted to be able to provide a full spectrum of surgical services for my patients. And so I started my Mohs fellowship here at Dayton Skin Surgery Center. So far, it's been a blast.
Yeah, that sounds so fun. I've had a few people on that do Mohs, and it's so fascinating just seeing how it's done and knowing that it's making such a huge difference, but it's such an important field and it's very, very detailed.
Yes, there's a lot of little intricacies involved, but I think the most gratifying part of it is being able to have the patient walk out the door at the end of the day, knowing that their skin cancer is gone. And usually they walk out kind of completely fixed up as well, and we're really sort of a one-stop shop for folks with skin cancer that need surgical treatment.
Yeah, absolutely. When you think of cancer in general, you think of it as a long healing process. So knowing that you can go in and get it taken care of pretty quickly is really amazing. So tell me more about what you guys are doing and I know you guys have a new nonprofit. Tell me a little bit about that and what it is.
Well, thank you. I'm very excited to share more about iTask, which is our nonprofit organization. It stands for Improved Treatment Access for Skin Cancer. And the mission of the organization is to provide Mohs surgery treatment to all patients with aggressive skin cancers who need it, regardless of their ability to pay. So, the impetus for the formation of this organization came many years ago when our founder, Heidi Donnelly, who is a Mohs surgeon here at the practice, she encountered folks in the Dayton area who had skin cancer, oftentimes on their face or in other really noticeable locations, and who needed treatment with Mohs surgery, but were unable to afford it. And so we're just living with skin cancer, and it was affecting their lives, it was affecting their relationships, their ability to find work. And through that process, she treated some of those patients in her practice, and seeing the need, decided to create this organization to help connect those patients who don't have access to care with volunteer surgeons who are willing to provide their surgery free of charge. And so the organization was founded in 2019, and the first few years went into developing an online referral platform to allow clinics where these patients first make contact and are diagnosed with skin cancer to then refer those patients through the iTask platform. And then we will connect those patients who are referred with a volunteer Mohs surgeon in their area who can provide them with free Mohs surgery treatment. And so
Wow.
we developed a platform and then launched our efforts in a 14 county region of Southwest Ohio last July. And it's been a really gratifying experience.
Wow, that's amazing. I mean, you think about the cost for any kind of surgery, in general, now with healthcare being so expensive, a lot of the patients that I work with that are trying to get, their psoriasis medications or for any of these chronic diseases for the biologics, that's so expensive. So, I mean, what would that typically cost somebody? Do you even know like an average of what somebody would pay for a surgery like that?
The cost it can be variable, but it's on the
Mhm.
range of, a couple of thousands of dollars
Mhm.
typically from start to finish, including all the follow-up care that's required. And so, it's a pretty hefty amount. And certainly there are many folks out there who cannot afford it. We did some estimates in terms of the magnitude of the need for these services within our iTask service area, which as of now is a 14 county region in
Mhm.
Southwest Ohio. And we estimate that there are over 300,000 underserved patients, and those are patients who are both uninsured as well as patients with Medicaid, because oftentimes patients on Medicaid cannot find a Mohs surgeon within their geographic region who accepts their insurance. And so, there's about 300,000 patients, and about 450 a year within that group will develop skin cancer that would qualify for Mohs surgery. And, what happens to them? Well, some of them just live with it and don't receive treatment. Others will receive inferior treatments that don't have as high of a cure rate as Mohs surgery, or that result in more disfiguring scarring. And then, there is a portion of those patients who, the cancer progresses far enough, it affects their health, and can even, lead to their death. And so it's a really real issue. It affects a lot of people in this area.
Yeah. So you said 14 Mohs surgeons right now. What is the goal as far as just how widespread do you want this to go, or just in Ohio, or would you look at other states as well?
Well, we decided to start in our local area in order to test the platform, kind of see how things are running. And now that we have, got the system, it's an online based referral system, so it's very scalable. Our goal is to continue to expand over time. So we certainly want to expand to cover the rest of Ohio as well. And from there, we would love for this to become a nationwide platform and that's obviously going to take some time to kind of establish the relationships between the referring physicians and create the network of volunteer surgeons. But that's our goal in the long run.
So then how do patients find out about this?
That's a good point. We have been trying to get the word out in many ways. We've partnered with a lot of local organizations who have been generous enough to contribute to our efforts, including the Gala of Hope Foundation here in Dayton, Castle Biosciences, and the Skin Cancer Foundation. All of those organizations have pitched in to not only help contribute to our efforts, but to help publicize our efforts. And so we have been trying to get the word out through social media, as well as other forms of media, the news, radio, to try to reach our patient population.
Yeah. So when patients are diagnosed with skin cancer and the doctor says, okay, you need to have surgery, is it typical to get referred out?
Yeah, that's true. The number of Mohs surgeons across the United States is quite limited, and the distribution is also, not equal in all areas. And so sometimes as you get closer to larger cities, you'll have several Mohs surgeons sort of clustered in that area. But as you get into more rural parts of the country, you might not have a single Mohs surgeon for hundreds of miles. And so that can certainly be a barrier, which is why it's even more important to finding someone who is within the same geographic region as the patient to provide treatment, because a lot of these patients who don't have health insurance also don't have access to reliable transportation to be able to travel several hours to go have a surgery done.
Yeah. Walk me through the steps for Mohs surgery. I know patients are there for a long time. You have to do labs, or what all is included in that?
So the first step, when a patient walks in with a suspicious lesion to their dermatology clinic, they have to undergo a skin biopsy to get a diagnosis for their skin cancer. If their skin cancer falls within one of the categories that can be treated by Mohs surgery, which currently through iTask at least we're focusing on basal cell and squamous cell skin cancers, which are the two most common types of skin cancer. There are certain criteria that help determine whether Mohs surgery is the most appropriate treatment for them. And so that takes into account factors such as location on the body, if it's in a high risk area, such as the face, and also the aggressiveness of the tumor based on the biopsy results. So if a patient qualifies for Mohs surgery, then they get set up for an appointment with their Mohs surgeon. And they come in usually early in the morning, and the surgeon evaluates them, takes a look at the spot where the biopsy was done, and marks out what they see as the borders of the skin cancer with the naked eye. And then they get numbed up, and that piece of tissue is removed and is taken to the lab, which is on site. And that tissue is processed, and that process can take an hour or two, and slides are prepared from that tissue. And then the Mohs surgeon takes a look at those slides, and what they're evaluating is 100% of the margins of the specimen. So they look all the way around the edges of the piece of tissue that's removed, as well as at the base. So you can sort of think of it as like a deep dish pizza. And so you're evaluating all the crust around there to see if there is any cancer that reaches the edges. If any of the edges are positive for cancer, then the Mohs surgeon goes back and takes more just in the area where the tumor is positive, and the process repeats until the cancer has been completely removed, which is why the patient may be there all day at the clinic, because we don't know if we're going to get it on the first try. About 50% of the time we do, but sometimes for the most aggressive tumors, the roots are microscopic, and so you can't tell with the naked eye how far it extends. And so sometimes we have to go back for 2, 3, or more stages. Once the tumor is completely removed, then we turn to the reconstruction. So the patient is left with a defect in their skin that needs to be repaired in a way that is going to be cosmetically appealing, but also is not going to impair their functioning. If it's a defect that's close to the eye, it can affect their eyelid and their ability to open and close their eye. If it's close to their mouth, it can affect their ability to eat and speak. And so the surgeon, designs a reconstruction that will be the most optimal through a joint decision-making process with the patient. And then in most cases, the patient gets stitched up the same day before they leave.
Wow. So there's a lot of training that goes into it. But aside from the surgery part, you also have to train a cosmetic surgeon, essentially, right?
Yeah, so there are three main, parts to the Mohs procedure, as we mentioned. One is the skin cancer removal. The second part is the pathology, because the surgeon is the same person who evaluates the pathology, looks at the slides under the microscope. And then the third is the reconstruction. And so, yes, there are, plastics and reconstructive surgical techniques that the surgeon has to master in order to be able to fill all of those roles and provide a good outcome for the patients.
That's so amazing what you do. And so as a fellow, what exactly is that? How long is that training? You're training behind Dr. Donnelly, and how long is that?
Yeah. So, after you complete your 3 years of dermatology residency, you can choose to pursue an additional fellowship in Mohs surgery. The majority of fellowship programs are 1 year. There are some that are 2 years in length. And during that time, you participate in Mohs surgery under the supervision of an attending physician. So at my program, Dr. Donnelly is the program director, and then there are several other Mohs surgeons as well with whom I train, and they're all great surgeons who have been very impactful in developing my skills.
Wow. The surgery part is really exciting to me. This was years ago. I got to assist on like a closure, but it was not for a Mohs surgery. It was just for like a biopsy or something. It wasn't like crazy big, but I don't know. It was just something interesting about doing that when you're having these Mohs surgeries and you have a really difficult like or deep closure. I mean, that's some serious cosmetic work. Like, how do you avoid having those scars left behind?
Every case is different. And so you have to take into account a lot of factors when it comes to the individual patient, both in terms of their lifestyle, kind of what they're going to be able to manage and put up with, whether it's, the day of surgery, how much they can tolerate in terms of a big reconstructive procedure. There are other health factors. whether they have the social supports in place that are be able to help them with wound care afterwards. But we've got a lot of techniques to fill big holes that are made from skin cancer removal, whether that is skin grafts or borrowing skin from other parts of the body to patch up a hole if it's too large to stitch together in a straight line. We also use flaps, which, involve moving adjacent skin in to fill a hole in a cosmetically sensitive area. And so there is a variety of techniques. There are hundreds of different flaps out there that dermatologic surgeons use, which is why it's a year-long training program.
Yeah, definitely. How is the education side for patients? And because I mean, this is something that you probably want to get done as quickly as possible to avoid it being a really deep, skin cancer. So, how do you educate patients as far as what to do, how to prepare for it in the beginning, but then also the aftercare and how to take care of their skin and all of that as well?
Right. So, this is a very common scenario that we face because 1 in 5 Americans will develop skin cancer at some point in their life. And this is the most common type of cancer. So we get patients very often who are dealing with their very first skin cancer. And so they have no idea what to expect. And hearing the word cancer is scary. And so there's a lot of, anxiety. They may have had, friends who have dealt with other types of cancer and be kind of drawing from those other experiences. And what we have to do is sort of kind of investigate what they are coming into the conversation with, what sort of preconceived notions that the patient has, and then try to provide information and meet them where they're at, and then provide recommendations along with that. And so the way that I approach it, it really depends on the type of cancer that we're dealing with. So the most common type of skin cancer is basal cell skin cancer. And so for folks who are dealing with that, I tell them, well, the good news is that, this type of cancer, basal cell skin cancer, does not tend to spread anywhere else in the body. So it's a local issue, but it is something that needs to be dealt with because, these cancers have roots over time. They grow, they invade important structures, and we have very effective treatments for the majority of skin cancers. So Mohs surgery has a 99% cure rate for basal cell skin cancer, 97% for squamous cell skin cancer.
What are squamous cell? What's the difference?
So squamous cell is the second most common type of skin cancer. They're derived from slightly different cell types in the skin. Squamous cell does have a small chance of spreading to other parts of the body if it's left to grow, typically for longer periods of time. It has a higher chance of spreading, whereas basal cell really doesn't tend to spread very often at all. Then, of course, there's melanoma, which is a completely different discussion in and of its own because it tends to be a much more aggressive type of skin cancer, even from early stages. And so, it's kind of presenting the patient with facts, but also, addressing the emotional side of things. That's the first part. And then talking them through the Mohs procedure, if that's what they're going to choose to have. If they have a cancer that would be better served by treating with some alternate modality, there are, topical medications that can treat skin cancer. There are other procedures in addition to Mohs surgery that we sometimes use. And so I like to present all of the options to patients and explain what the pros and cons are of each option. And I think, as patients become more informed and start to understand, that helps develop the trust. And then we come to a joint decision in terms of what the best course of action will be and proceed from there.
Yeah. So about how much time do you spend in the room counseling patients on that?
Not all of this happens in the room because, on
Okay.
the general dermatology side of things, you see a patient, they have a suspicious lesion. You may, kind of mention to them the possibility that this could be skin cancer, but you don't have the confirmation yet. So you perform a skin biopsy, get the report maybe a week later. And then, I typically will call the patients and have a conversation with them. Some patients, who have experienced this before, it's a 1 minute conversation where they're like, oh yeah, yeah, I've got another one, time to get Mohs. For other patients who, are dealing with this for the first time, that can be a 15, 20-minute conversation in terms of talking through all the options. And then when they come in on the day of surgery, we have another kind of opportunity to touch base with them before the procedure begins to ensure that all of their questions are addressed. And then, throughout the day as well, that's one of the things that I like so much about Mohs surgery is that the patient is awake throughout the entire procedure. It's all under local anesthesia. And so we have lots of conversations with our patients over the course of the day, both related to, the skin cancer they're dealing with, as well as, all other aspects of their lives. We learn a lot about our patients, and that's one of my favorite aspects of the job.
Yeah. So if you have a patient that comes in, would your first option be something topical, or based on that biopsy or based on how it actually looks? This looks like it might be pretty deep. skin cancer that we might need to do that surgery? How can you tell from
Yeah, so
looking
there's a
at?
lot of nuance that goes into the decision-making process. Some of it depends on the type of skin cancer, whether or not it has a likelihood of spreading elsewhere. The other piece is the depth, as you were mentioning, kind of how deep the tumor goes. So topical medication tend to be more effective for more superficial skin cancers that are caught early or only in the very top layer of the skin. But even then, the cure rates are lower than for surgical treatments. And so, oftentimes the topical medicines will have somewhere from a 60 to 80% cure rate as opposed to the surgical treatment. So, I will present all the options to the patient, and oftentimes they will, express a preference, one way or another. If they are someone who's, more of a minimalist and would like to, kind of try a topical treatment first, we'll choose that route. It's often, several weeks to months of treatment. And then we'll follow up afterwards and kind of ensure that things have resolved. If not, then we sort of escalate up the treatment ladder from there.
So you said that squamous cell was the one type that spreads. Does that spread to other parts of the body or different types of cancer?
Right. So of the three most common types of skin cancer, your basal cell is most common. That one doesn't tend to spread. Squamous cell is second most common. Still has pretty low rates of spread. In general, the vast majority of squamous cell skin cancers that we see in the clinic are just local skin limited issues. But it does have the potential to spread. So it can spread from the skin to the lymph nodes, and from there it can spread to organs throughout the body. And we do see that, especially in cases where the cancer has been left to grow for many years. There's a higher likelihood of that. And also in specific patient populations that are at higher risk. So patients who are immunosuppressed, specifically organ transplant patients, tend to have both higher rates of squamous cell skin cancers and more aggressive squamous cell skin cancers. So yeah, they can spread, to various parts of the body, from the lungs, the brain. And then melanoma, is also, highly aggressive, and it has a much higher likelihood of spreading than the other two types of skin cancer that we mentioned. And so oftentimes, we will stage the melanoma based on the depth of it, and that helps guide our decisions in terms of, whether more workup imaging will be helpful to identify the risk of spread.
So my sister had Mohs surgery, and knowing that, it's kind of made me a little bit more conscious about, you know, making sure I'm wearing sunscreen and making sure my
Sure.
daughter's wearing sunscreen and, all my family members. I was talking to her about it. She had made a comment about it's not like I was laying out in the sun. What are some other causes of skin cancer? And could it be products that we're using, or, what else could be causing a skin cancer?
Sure. I think there are a variety of factors, and we likely have not even identified, all of the potential risk factors that may contribute to development of skin cancer. I will say, sun exposure by and far seems to be the greatest risk factor. And it's not just, bad sunburns, as, most people are aware that that's not a good thing and that can increase your risk of skin cancer, but also low level chronic sun exposure over the course of decades can build up and predispose one to skin cancer. Beyond that, there are a variety of other factors that can play a role. Certain medications that folks will take for a variety of different health issues can predispose them to skin cancer. Any medication that makes you more sensitive to the sun and makes you more likely to burn can sort of indirectly increase your risk of skin cancer. And then there are other chemical exposures, arsenic exposure is one, and then radiation exposure as well. So there are a variety of other things that may play a role as well, including genetic factors as well.
I was going
But
to ask
I
next.
think the most easily modifiable risk factor is sun exposure. And it's not sun that you're getting now. It's usually sun from, 10, 20, 30 years ago. There's a delay between when you get the sun exposure and the damage to your cells and when those changes manifest as skin cancer. And so a lot of the damage, unfortunately, is done in our teens and 20s before we know any better. And so that's why, it's even more important, I think, to be able to reach young people and to inform them of the risks.
Yeah, absolutely. I'm always talking to, my nieces and nephews and all my family members, just making sure that, hey, did you put your sunscreen on? Did you reapply your sunscreen? Especially when in the summertime, when you've got all kinds of events going on and things happening and kids running around, and they tend to forget. Even at the pool, I think that's a big one. In and out of the water. And if it's not waterproof, I guess, I don't know how well does that actually work if you're in the pool and you put sunscreen on and you get out and you're not reapplying.
Yeah, the reapplication piece of it is so important. Just on even on a general basis, even if you're not in the pool, the recommendation is if you're outdoors every 2 hours, you should be reapplying. And it's difficult. It's not an easy thing to keep up with if you're out at the beach, having a fun day to remember to reapply sunscreen. But I'm glad that you stay on your family members. They may not appreciate it now, but I'm sure, down the road that they'll thank you for it.
Right. I know. I try. Okay, so lastly, as far as the type of sunscreen that's the best, I know that there's so many different ones, and there's a new one that I've actually just saw that's for darker skin. My daughter's got darker skin, so trying to put something on her, and then she's got this, purple tint or different tint to her skin because she
Mhm.
put the sunscreen on, and if it's not rubbed in all the way. So, what are the good ones and what are the bad ones?
Sure. Well, I don't know that there is a bad one per se, but and you'll find differing opinions on this, but I'll sort of give you my perspective on it. The main categories of sunscreens, there are chemical sunscreens and mineral-based sunscreens. The studies suggest that the mineral-based sunscreens have a broader spectrum of protection. So there are a lot of different types of UV light, and the mineral-based sunscreens, which are the ones that are primarily zinc or titanium-based, those block a broader spectrum of UV rays, so they give you better protection. So those are the ones that I tend to recommend to my patients. Now, for patients with darker skin, there are, some unique things that you need to take into account because obviously you don't want a sunscreen that's going to leave a whole lot of whitish residue that's going to stand out from the skin. And so there are tinted sunscreens, which are now on the market as well, which you can match to your complexion. The benefit of the tinted sunscreens is that they actually provide an even broader spectrum of protection than just the normal mineral-based sunscreens because they block visible light in addition to UV radiation. And so they offer the broadest spectrum, which not only will help reduce your risk of skin cancer, but also helps prevent some of the aging effects that the sun has on our skin over time. And so that's a really good thing to look into as well. But in general, mineral-based sunscreens and then add the SPF number is important. The higher the better, but I think an SPF of 30 at least will give you a good baseline of protection.
Okay. So I have heard before that anything over 30 doesn't really do much. Is that true?
There is additional benefit to a higher SPF level, so an SPF 50 compared to an SPF 30 or even SPF 100. There is additional benefit. It does block more of the sun's rays, but the marginal benefit from a 30 to a 50 and a 50 to 100 sort of decreases as you go up. And sometimes those higher SPF sunscreens can be a lot thicker and pastier. So, it's sort of a balance. Of course, if everyone was able to use SPF 100, that would be ideal. But in reality, we find that that's not going to be the case for most folks. And so SPF 30 gives you a good baseline of protection. So that's kind of the minimum that I recommend.
Okay. Well, thank you so much for joining me and talking about the Mohs surgeries. I think that is really exciting, but also just knowing how to take care of your skin and understanding, how to prevent having to have a Mohs surgery. But if you need help or that to be affordable for you, I think it's such an amazing thing that you all are doing. And hopefully we get the word out and connect with more people so that they can know about this and make sure that patients are aware of it as well. I think that's absolutely amazing. So thank you so much.
Well, thank you for having me on. It's been a pleasure having this conversation with you. And if you or if any of the listeners are aware of any people who are struggling to access treatment for their skin cancer, please go to www.itasc.org. We have some contact information on there. You can reach out to us and we can see if this is a patient that can qualify for our program.
Absolutely. And then what if there is a Mohs surgeon that is interested in joining as well? Would they go to the same website?
Yes, we would love to have them. They can go to the same website. There is a volunteer surgeon sign up form as well that they can complete, and then someone from our organization will reach out to them.
Sounds good. Thank you so much. It was such a pleasure talking with you.
All right. Take care.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.